you. This is myself, Dattatreya Hudge. I'm based at Pune from Emcure Pharmaceuticals. So, welcome you all the faculties and delegates on this session of No Thrombosis workshop. So, today's course director, I will introduce course director Dr. Subhash Kaul sir, senior consultant and stroke specialist at KIMS Foundation and Research Center, Secunderabad. Sir is faculty for 27 years in Nizam Institute of Medical Sciences, Hyderabad. Sir is former professor and head Department of Neurology and Dean at NIMS. Sir has 120 publications in national and international journals. Sir is principal and co-investigator of several national and international projects, including largest single center Hyderabad Stroke Registry funded by ICMR. Sir is past president at AP Neuroscientist Association, Indian Stroke Association, and Indian Academy of Neurology. Welcome, sir, on this forum of the No Thrombosis workshop.
Thank you. Thank you.
Yes, sir.
Please go ahead.
Yeah. So, our today's moderator is Dr. S. Meenakshi Sundaraswamy. Sir is senior consultant neurologist, Apollo Hospitals, Madurai. Sir has over 20 years of experience in neurology. Sir has presented many papers at prestigious national and international forums. Sir has received the Best Research Paper Award at 10th Annual Conference of Indian Academy of Neurology in Lucknow 2002. Sir is principal investigator for many international trials such as refractory partial epilepsy, stroke, acute stroke intervention trial, and PD trial. Sir is editor of the South Asian edition of book Practical Neurology, and Sir is also contributed to many books on neurology. Welcome, sir, Dr. S. Meenakshi Sundaram on this forum.
Thank you very much for the opportunity, sir.
And our today's moderator is Dr. S. Shamlal. Yes, sir. Sir is senior consultant neurologist and academic coordinator, Department of Neurology, KIMS Health, Thiruvananthapuram. Sir is in charge of comprehensive stroke unit and multiple sclerosis clinic at KIMS Health, Thiruvananthapuram. Sir is faculty and examiner of DNB Neurology Training Program by National Board of Examinations. And Sir is clinical supervisor for IMT Internal Medicine Training Program by Royal College of Physicians. Okay. I welcome Shamlal, yes, sir, on this forum.
Okay, thank you.
Then our today's first speaker is Dr. Satyananda, sir. Sir is senior consultant, head of neurology department at Yatharth Wellness Super Specialty Hospital and Heart Care Center, Noida. Sir has worked at consultant Ayushman Hospital, New Delhi, then BLK Max Super Specialty Hospital and Batra Hospital, New Delhi. Sir is awarded bursary for attending 23rd World Congress of Neurology under the aegis of World Federation of Neurology, Kyoto, Japan. Then Sir is awarded bursary at attending 24th World Congress of Neurology under the aegis of World Federation of Neurology, Dubai, UAE. Sir has presented many papers at various prestigious national and international forums. Sir has presented a poster titled A Pilot Study on the Mapping Structural and Functional Connectivity in Early AD in Comparison to Stable MCN Healthy Controls at 23rd WCN at Kyoto, Japan. Sir, welcome you on this forum as a speaker. Then,
thank you.
Our tonight's speaker, Dr. Akash Chheda, sir. Sir is associate professor at Sir JJ Group of Hospitals, Mumbai. Sir has fellowship in epilepsy in KM Hospital, Mumbai. Sir has 7 publications and 9 paper presentation at neurology conferences, including award paper on a systematic and quantitative evaluation of plantar stimulation presented at ANCON 2017 Chennai, which was among top 6 selected papers on presentation. Sir, I welcome you on this forum of No Thrombosis. So, welcome all delegates, and I hand over this session to our course director, Subhash Kaul sir, Dr. Subhash Kaul sir, for the contest setting. Sir, over to you.
Yeah, yes, thank you very much. Can you hear me?
Yes, sir.
Yeah, okay. I think once again, it's a pleasure to attend this session. And as everybody knows that this is a case-oriented program in which we learn from the individual case and the challenges it throws, and then we have a mutual discussion. So without doing much ado, I would request Meenakshi Sundaram and the other chairperson to please take the program forward. Dr. Meenakshi, can you please start the program and invite the speakers?
So thank you very much for the opportunity, sir. Waiting to hear from the 2 speakers for 2 exciting talks. And as usual, sir and my co-chairperson will be guiding us through this program. Thank you very much, sir. When stroke takes us for a ride, we can say that Dr. Subhash Kaul sir will be going for a ride. Thank you, sir.
Yeah. Please go ahead. Meenakshi, you're not audible. You're not audible, Meenakshi.
Mute.
My other co-chairperson could give a comment, and then we can straight away go for the cases, sir.
Yeah, we can start the cases, because I think this is the second time I am attending this Know the Thrombosis course as a chair or a moderator. Okay, it's a very interesting sessions, and we will learn a lot from the experience of other people. So we can start presenting the cases. Okay.
Sure.
Dr. Satyan?
Yeah, I'll start. Warm good evening to everyone. Thanks a lot for giving me this platform to share my experiences with interesting cases of thrombolysis, IV thrombolysis, that is. So I'll go. Yeah, I hope my slides are visible. So I'll start with the case presentation. He's a 50-year-old male. He is a known case of hypertension, and he was brought to the emergency to the neurology OPD with the chief complaints of acute onset inability to speak, which was noticed since 8 a.m. Actually, he was working on a night shift, and from his return from night shift, he works as a security guard. So he came and he was not able to speak. That is what the attendants noticed, and that's why they brought him. And the stroke onset was unwitnessed, and due to the deficit, the patient was not able to communicate the exact time of onset because he was not able to speak by himself. Thereafter, the attendants noticed an hour later that he developed a weakness of right upper and lower limb, which was sort of worsening by the time the patient had come to the presentation. By the time the patient been brought to the OPD, he was brought to the OPD at around 1 p.m. So the symptoms were noticed at 8 a.m. and he was brought at around 1 p.m. That is at least 5 hours after the onset of symptoms. So his examination, he had fairly regular vitals, and the CNS examination showed global aphasia, and the power of right upper and lower limb had dropped to 0/5. The NHS score scale was 14/38, and because of the unwitnessed stroke onset and the fact that the patient was outside the regular window period of IV thrombolysis, I considered going for an MRI brain for this patient, and this is the diffusion sequences of the MRI. So as we can see, there was a stroke. There were two foci of hyperintensity, one in the posterior part of the left hemisphere and one in the mid part of left hemisphere, corresponding to left frontotemporal region and left parieto temporal region. So the next sequence in question was FLAIR, whether these changes had appeared on FLAIR, were they a FLAIR positive or no. So this is the FLAIR sequence. So as we can see, this the posterior part of the stroke corresponding to the posterior part of the left hemisphere was diffusely hyperintense on FLAIR images. Playing it further, the region corresponding to the left frontotemporal region, frontoparietal region, was not FLAIR hyperintense, and this was concordant with the history also given by the patient's caregivers that when he came, his deficit was only of inability to speak, and thereafter he developed the weakness of right upper and lower limb. So maybe two strokes at different point of time, which had been witnessed in the patient. So thereafter, there was no blooming on GRE images. There was no absolute contraindication for proceeding with IV thrombolysis in case we were to go by a perfusion scan. So next step was to look at the brain blood vessels, that is the CT angiogram. And CT angiogram, sorry for the background noise. So there was no major vessel occlusion, which was amenable to mechanical thrombectomy. So considering the options available with us, the only possible option was to consider for IV thrombolysis if the patient classified for thrombolysis in extended window period, that is beyond 4.5 hours up till 9 hours. So we needed further imaging. We needed further CT perfusion imaging to delineate whether the patient had a salvageable tissue or no. And thus we went about doing the CT perfusion imaging. And this CT perfusion imaging showed that there was a reduced CBF, which was out of proportion to the CBV in the left MCA territory. We sent these scans for the artificial intelligence also, and artificial intelligence by means of rapid software also processed the same. And they also, and the results of that imaging was also that the mismatch volume was 16 ml and the mismatch ratio was 2.8 in that same territory. That is CBF less than 30% was 9 ml and Tmax more than 6 seconds was 25 ml. So there was 16 ml of potentially salvageable tissue, which was to be salvaged if we were to go ahead with IV thrombolysis. So thus the case was discussed with the caregivers, and we decided to go ahead with IV thrombolysis after explaining the due risk and complications. And the patient was thrombolized with tenecteplase, 0.25 mg per kg bolus, and he was given 13.75 mg. The bolus was given at 2:10 p.m. That is 6 hours, 10 minutes after the symptoms were first noticed. So, and thereafter, the patient had an improvement and the patient had a good clinical recovery and he was discharged ambulatory by self. The only deficit he had was that he was still having aphasia and the facial weakness was mildly persistent. He was able to ambulate by himself. So this is the patient video at the time of discharge. Yeah. So his name is Hari Singh. So he's not able to say his name. He has motor aphasia, but he was able to comprehend the commands. So this is the outcome of the patient, and at the time of discharge, he had these deficits: motor aphasia and mild right side facial palsy. We wanted to do a CT follow-up CT, but because the machine was down, we had to do an MRI scan, and MRI brain actually was a post-thrombolysis scan. That is, it did show devolution of the infarct, but by and large, the area which we wanted to salvage in the penumbra, a portion of it had been salvaged, and the patient had good clinical outcome. So, with regards to evidence as to do we have any evidence with regards to advanced thrombolysis and the thrombolysis in the advanced window period, that is 4.5 to 9 hours, we do have that by ESO guidelines also. They also state that if the patient has an ischemic stroke between 4.5 to 9 hours and we are able to demonstrate a perfusion mismatch, which is characterized by infarct core volume of less than 70 ml, excuse me, and the volume ratio of hypoperfusion to infarct volume of more than 1.2 and mismatch volume of more than 10 ml, the patient should be considered for IV thrombolysis. And this is the same thing which we considered. And the perfusion imaging does vary between multiple studies. Some of them take the mismatch ratio as 1.8 and the mismatch volume to be more than 15 ml. So by and large, we can go as per our clinical discretion also, as the area is eloquent. So we should be able to thrombolize even if the volume is of around 10 ml. And the core volume should be less than 70 ml and core should be less than 1/3 of the territory of MCA. Thank you.
Yeah. Can you hear me?
Yes, sir.
No, I think congratulations. I completely agree with your case. I mean, this is perfect as it can be, because you have done the latest technology of perfusion studies. And in fact, this is the technology which has extended the window period up to now. Say that in some studies have taken 1.8 as a mismatch ratio, but those studies are for dawn and diffuse for the mechanical thrombectomy. But for this IV, they have taken one only in that trial. I think I would do exactly the way you have done. So thank you very much. Meenakshi, any comments?
Sir, a very nice case. Thank you so much. Only one question I need to ask you. In our hospital, for example, typically we do the MRI diffusion and flare, and then we go ahead and thrombolize them. So I'd like to know whether we would be consuming more time trying to do CT perfusion study additionally. Was it really required? Because now we have enough data, at least the extent data, the ECASPORT data, as well as the wake-up stroll data. All of them have been put into one meta-analysis to show the benefits. So should we really do the software and do advanced studies before doing it? Or you would teach us whether we can directly go ahead and do it with only diffusion flare mismatch? Is it good enough at this point of time?
Because we are moving from a time-based window to a tissue-based window, so in the extended window period, if it's a wake-up stroke, I would definitely agree that diffusion flare mismatch only would be sufficient. But because the patient had a stroke onset which was unwitnessed and he had already presented to the hospital after 5 hours, so therein was the confusion and the necessity for which I felt, excuse me, for a perfusion study. So as to note as to whether there would be any benefit which would be gained in terms of volume of the tissue which would be salvaged.
No, Meenakshi. See, conceptually you are very right. Conceptually, I mean, conceptually it makes sense, but it depends upon the trials which they have done. That trial of diffusion perfusion mismatch was done only in wake-up strokes. For non-wake-up strokes, somehow they have not done that trial. Although in principle it should work there also. And our Pawan Oja from Mumbai has published some 10 cases or so where he has shown even in non-wake-up strokes it works. But the trial that was done done only on wake-up strokes. That is the limitation. So I think that is why our speaker has done perfusion study. Yeah.
We could have then straight away gone for CT perfusion without MRI. How would that be, sir? Is that okay, sir?
Yeah. He could have done this. Yeah, that is one good suggestion. That he could have straight away gone to save some time. That's true. That's true. How do you respond to that, sir?
So the only concern was whether the area involved was more than 1/3 or no, and that would have been given in evidence by perfusion imaging also. I agree. The protocol should have been could have been CT with CT perfusion also. That should have also worked the same.
Yeah, that's a really positive suggestion. The only thing I would react is that we are used to see MRI. You know, that 1/3, 2/3, we are used to see that white infarct, and CT scan, we are not, our eyes are not now that trained to. But otherwise, that's an excellent suggestion put by Meenakshi, because by that time we could have saved another 15-20 minutes, some 15 billion neurons. So the point is well taken. Yeah. Yes, Meenakshi, your points are always extremely innovative and good.
Sir, one more doubt I have, sir. The studies have shown up to 9 hours. I would like to learn from you, what is the harm in extending beyond 9 hours also? What is the magic of 9 hours, sir?
No. It is just, you see, when they do a trial, they take some set points. That is the only thing. Otherwise, there is nothing. It can work for 10 hours also. But we go only, in fact, studies are going on at this time. IV connect to place for 24 hours. I'm aware of those studies. They have been presented in conferences. I think before long, we will be having an extended window. It is just that we go, the guidelines go by the trial which are published.
Is not available.
Yeah. Okay, go on, sir.
Dr. Satya.
Shyamlal, sir.
Yeah, interesting case. Yeah, in our center, we usually didn't do these things because in our center has got a protocol in which we usually do thrombolysis for only up to 4.5 hours, and otherwise we will go for a mechanical thrombectomy and all these things if the vessel wall occlusion is a proximal intracranial ICA or proximal M1 M2 occlusion. But this is an interesting thing, okay, because the Dawn and diffuse trial was, we used the protocols of the Dawn and diffuse trial for the mechanical thrombectomy, and usually we don't go with this extended window period thrombolysis till now, okay. But I think this may come into our guidelines also soon, okay. As a recent ESO guidelines we were quoting was okay, but we have not started at doing it. We may, okay. Thank you. Interesting case.
Thank you, sir. Thank you.
Thank you. Nice. I'm a fan of extended thrombolysis.
This patient, did he have?
Yeah, but Meenakshi, go ahead.
Sir?
Go ahead, please. You are telling something, Meenakshi.
Did this patient have a major vessel occlusion? No. Did this patient?
No, he said no occlusion. He said no occlusion.
Sir?
No, sir. The angio did not pick up.
Show.
No, sir. Did not show a major vessel occlusion. Amenable to mechanical thrombectomy.
This much. Yeah, I really feel there was so much of good collaterals in that angio which you showed. They were perfusing all along despite the ischemia. Happy you could save at that time. That angio you can show us. It was a beautiful angio, really, I thought. Perfusing all the way up to the M4 level, it was perfusing. That's why the guy was just sitting there. Though he was failing, he was really doing well at that time. You caught him right in time before the collaterals also failed.
Yeah. Okay, good.
Yeah, so this is the CT angio.
Yeah. Really picture the angio's juice. And though those trials, whatever we are putting, are for altiplase, I think we have extrapolated and moved away from that, and we have gone to tenecteplase complete.
Yes. That is true. That is
no
true.
Need for. Thank you, sir.
Yeah, that is again a very good point, Meenakshi. You know, we often say that extended thrombolysis is for only alteplase, but he has shown that it's for tenecteplase also. That's good. That
meta-analysis included 4 trials, 3 trials. I think one was the ECAS, wake up, and then the ECAS 4 and epithet trial. I think they made that meta-analysis. Though they pointed out that it was the adjusted data that was favorable. Nevertheless, I think thrombolysis should be pursued, just not worrying about too much about statistics. And you have shown that it has given excellent result, really.
Correct.
Too much of statistics will only baffle us.
Yeah. Okay, great. Thanks.
Thank you, sir.
Can we go to second case?
Thank you, sir.
Thank you.
Are my slides visible?
Yeah.
Good evening, everyone. So, myself, Akash Chheda. I'm from Grant Government Medical College, JJ, Mumbai. And I've decided to show cases of stroke, which I've come across in last few months, which have perplexed me and have really taught me many things. So, starting with my first case, I thought it would be an interactive session. So, I've put in information which was available with me, but I'll give you all the background information whenever needed. So this is a MRI image, and the patient had come to me, come to us in the window period. The diffusion shows right MCA territory infarct involving the entire hemisphere involving deep gangliocapsular as well as the cortical region. There is corresponding ADC drop. The scan was done within first few hours, maybe 2-3 hours of the onset of symptom. The flare does not show anything. So the patient clinically was having left-sided weakness and was altered. She was restless. She had gaze deviation to right. She was not following verbal command. Her NIHS was high. Her BP was 180/100. So clinically, she was looking like large vessel occlusion. She was known to some doctor and she was admitted to a peripheral hospital wherein they couldn't manage to do an angio. They were able to do diffusion, flare, ADC. But she was moving in the MRI gantry. They were not able to sedate her and we couldn't get a angiography done. So we could see the images and we decided to thrombolize her with tenecteplase 0.25 milligram per kg. So we thrombolized the patient and we then decided to take her for DSA because we thought this is clinically a large vessel occlusion and we will expect something in the angio. So when taken for the DSA, her vessels were open. So it was tenecteplase which worked because she had received the dose very early. Maybe it was within 2 hours. But looking at the ADC, which was so dark, looking at the amount of diffusion which was involved, we were worried whether the patient will do well and whether we should directly take her for thrombectomy. But because we were not able to do an angio, because she was at a peripheral place and she was about to shift to a place which would have taken half an hour, we decided to thrombolize and then shift directly for a mechanical thrombectomy. On table, our angiography DSA showed normal thing. And this is our follow-up scan on the next day, which shows that only the posterior, that is temporoparietal region, which has got infarcted, whereas the anterior 2/3 we were able to salvage. So whether there was spontaneous recanalization or whether this is reversibility of diffusion, which is seen in less than 10% of stroke. So in this case, we found later that she had atrial fibrillation. Most likely it was a cardioembolic stroke, and tenecteplase helped us to remove the clot. We were fortunate that there was no LV clot and we could salvage the patient. On follow-up, the patient is doing well. Her power had improved and she is mobile at home. I'll go to my next case. Do we want to discuss it at each case or we discuss it at the end of my presentation?
Sir, you are muted, sir.
How many cases you have in total?
I have 5. Whatever we can discuss, we will discuss.
No, then if it is 5, then we should discuss case after case. Otherwise, we cannot remember all the 5 cases.
So every case has a different message and it has a teaching point. And these are practical problems which we face while dealing with. So I would like expert comments on this, whether we should never take a patient for DSA without knowing the angio, and how much is the spontaneous recanalization or reversibility of diffusion which we are seeing in clinical practice, and whether we will dare to intervene in such thrombolize such patients who are having this ADC picture.
So Meenakshi, you can respond to all these questions.
I would like to see the MR angio, sir.
Angio we were not able to do, sir.
It's not done.
MR angio was not at that time, sir. Because I'm not asking about the CT and MR as a protocol, we do the angio also directly there.
No, sir, patient was moving, so we were not able to salvage time. She was a doctor. So clinically, it was looking like large vessel. We saw this on diffusion and we said that we will thrombolize. And we would save time that instead of giving her anesthesia and sedating her, we directly took her for mechanical thrombectomy, thinking that it is large vessel occlusion. So this case taught me that howsoever we may think, but we should always have a CT or MR angio before taking the patient for mechanical thrombectomy. This was the take-home message for me.
In this case, for instance, even if the patient had any MR angio, suppose let us say the MR angio was done, there are only 2 things. One, the angio was showing an open vessel, which is very unlikely in this case with this big infarct, or there was no angiographic block. Any which way, after doing it, if the patient did not clinically improve, we would have taken up for mechanical thrombectomy to do the DSA. If we have the procedure, I think we would have definitely, because even that would not have made a difference. Only it would be priming us as to what we are going to do for counseling purposes, our decision to take him into the cath lab, in my opinion, might not have changed. The second
As she
thing, a
was-
good message. Sir, sorry, sir.
As she was known to a doctor, here we were having a liberty of taking decision. They had given us a free hand that do whatever is best for the patient. And patient did not improve after thrombolysis immediately. So she was shifted to other hospital. She remained drowsy. Her weakness was there. Till the time she was taken on table and we started the DSA, she was not better. And then next day she improved. So the diffusion reversed. This corresponding ADC next CT, which was shown, doesn't show that complete infarction. So that is very surprising and that is very rewarding, which we could achieve with thrombolysis with tenecteplase.
Sir, there are two things, sir. One is that about the recanalization. In the pre-thrombectomy eras, data is available, 25% spontaneous, 47% with thrombolysis, which was at that time only altiplase. And then with the advent of intra-arterial plus this bridge, it was around 63%. And that time only Mercy catheter was tried. The opening was up to 83%. So this data was available in those pre-mechanical thrombectomy eras. So this is one, in my opinion, if it had shown a big vessel occlusion, it was a message for us. And Sarah has taught us on few occasions as to how IV tenecteplase could do. That was also seen in the Extend IA TNK trial, wherein almost 10% who had proven occlusion, they did not have to undergo mechanical thrombectomy, did not have to be, that Bruce Campbell data was often quoted there. So this is one example of me. Second thing is that in this CT scan, some hypodensities are evolving. So the comparison with the diffusion was not available. Did they have another CT scan, say a couple of days later, sir? Was it showing the same thing?
Patient improved clinically. She was discharged on day 4, day 5, and since then she has been improving. There was no.
So is there any other CT scan available subsequently, sir?
No. Because she was improving, we didn't have a chance to do a repeat CT.
Because even if the CT scan had shown some hypodensities, I don't think it would matter for us, as you said. Clinically, they have improved, we wouldn't bother. But just curious to know whether it was another imaging after that, either a CT scan or an MRI.
We were planning to do an MRI to just know that diffusion has reversed, but we couldn't do it. It was academic, so we dropped it.
Yeah, I have one. Can you hear me? Because I'm from my mobile phone. Can you hear me?
Yes, sir. Yes, sir.
I have one question. You did a DSA in this patient eventually. It was a cerebral angiogram DSA.
DSA, yes. So DSA was normal.
The DSA was done. No. Listen to me. The DSA was done after IV tenecteplase or before IV tenecteplase?
After IV, we thrombolized the patient. We shifted the patient.
Yeah. Now I have two comments to offer. One is that it is possible, as Meenakshi says, that there might have been a block there, most likely, and tenecteplase has dissolved that, which it is very well known to do, right? So that is one thing. The second thing is that what was the idea of doing angiogram? Because even by the current criteria, for mechanical thrombectomy, if the entire MCA is involved, you don't do mechanical thrombectomy for them. For mechanical thrombectomy. For IV, you can do. For IV thrombolysis, they have relaxed that. You don't have to worry about the size of the infarct, even if its entire MCA is involved. But as far as the mechanical thrombectomy is concerned, usually if you go by guidelines, there is a upper limit of 1/3 of the MCA, which means more than 70 cc don't take up for mechanical thrombectomy. Of course, one can go beyond guidelines, but otherwise, this was a huge infarct. I mean, it was beyond, it was almost entire MCA. What do you think? You understand what I'm saying, my point?
Yes, so we were very afraid whenever we were...
This would have been a large core thrombectomy. I mean, you were planning to do a large core thrombectomy.
Yeah,
you understand my point, which is... Yeah. Not guideline based. This is a research topic. A lot of international meetings are on large core thrombectomy. I think maybe the doctor was interested in large core thrombectomy. It's not in guidelines yet. It is still in research.
This is one of the cases in which now they have started saying that even with large vessel occlusions, large core infarcts, it is better to have an open vessel rather than leaving the vessel closed. So these are the cases in which we can see reversibility of diffusion. So I think this is one of the cases.
Akash, may I say something? Akash, this
Yes,
is an
sir.
interesting case, and my suggestion is what you did is exactly the thing to be done, because in our center, in any patient with a large vessel occlusion, obviously this is a case of large vessel occlusion. It can be a proximal M1 occlusion. Okay, so whenever a patient with a proximal M1 occlusion, we usually thrombolize within 4.5 hours and take the patient to directly to cath lab after giving tenecteplase as bridging therapy. We will take to the cath lab and do the DSA. If the vessel is open, we don't do anything. If it is occluded, we will go with the mechanical thrombectomy. That is a usual thing we routinely do. In this case, the only thing is initially there was not an angio, but the diffusion weighted images show definitely there is a significant MCA M1 occlusion. And what sir was saying, aspects for less than 6, we usually avoid mechanical thrombectomy. But I think in our center also, aspects less than 6 means it should be either CT or in flare changes. In diffusion changes, with the aspects, there is no significant flare changes. There is a diffusion flare mismatch, and the aspects is even less than 6. It is better to proceed with the DSA and proceed with the mechanical thrombectomy if possible, because the chance of reversibility is very high. As you know, the diffusion flare mismatch rate is 4.5 hours. So that means there is a potentially salvageable area. So in this case also, I think what you did is exactly the thing we should do, because that is what we usually do, because we don't know the vessel status. When we do the DSA, we exactly know the vessel status, and whether we can proceed or not, we can decide based on that. I think this would have been an interesting case, even though there was no angio in the initial phase of the presentation.
Thank you, sir. We'll move to the next case.
Sir, only one more comment, sir. If you may permit it. Sir, what Subhash sir was asking was, now when we do the mechanical thrombectomy, sir was saying that within guidelines, now we have taken even a large core infarct up to aspects 3. And aspects is scored on diffusion, isn't it? It is not scored on flare. So up to aspects 3 they allow. This is almost aspects 1, I think. So is it okay to still take it? So use the mismatch in this and take it. That was the first question. The second thing in this, that you said it's a cardioembolism. It's a good point for us to realize that cardioembolism, sometimes the deficits even spontaneously improve. It's called as the shrinking deficit syndrome. So it was one of those cases. Those are 2 doubts I have, sir. Is that okay to take? Because aspects, how much will be the aspects in this? Sir, 1 aspect at best. That was what Subhash sir was asking us, I think. Is that correct, sir?
Yeah. The question, may I answer? The question was exactly what Dr. Meenakshi was saying. This case, maybe the aspects will be around 2 or 1 only, because it's a proximal M1 occlusion with an significant diffusion restriction. But as you know, aspects was actually CT-based imaging only. Okay, aspects is actually CT imaging, but nowadays we use it in the diffusion flare and all, we use these things. But in any patient with the proximal M1 occlusion, when we do an diffusion weighted sequences, we expect it to be, the aspect should be less than around 1 or 2 only. So in that cases, practically what we do is, if there is a significant flare changes also in all the areas, we don't go for a DSA. And if the patient does not have aspects is even 3, if the flare changes is not significant, or if the duration we are sure, then we will proceed with a DSA. That is, the duration is less than 2 hours or 3 hours, very early period of stroke. We will proceed with the DSA and proceed with the mechanical thrombectomy if it is salvageable. But the most important thing is there should be the window period. The patient should be in the window period. If it is a 6 hour with the aspect score of 2, we won't go for a mechanical thrombectomy and all, 5 hours and all. But if it is within 1 or 2 hours, the diffusion changes are there and aspects is less, we will proceed with the DSA and mechanical thrombectomy in our center. We usually encounter in our center. Okay.
This was at 2 hours. So we had,
that's the most important thing. The window period duration is the most important thing in taking a decision regarding the DSA and mechanical thrombectomy in any patients with the low aspects.
Yes, sir. So coming to the second case. So this was the second case. He is an engineer and he stays next to the hospital. He had come with 15-20 minutes history of difficulty in speech and was not able to communicate, was not feeling good, and he felt something is abnormal. So I got a call and we did his MR angio because he was feeling anxious. He was not feeling well. He would cry and he would say that I'm not able to speak. He has got diabetes, hypertension, slightly obese, and was not on regular treatment for his diabetes. So before me coming, I said that we'll do an MR angio. And this MRI was reported as normal. So this MRI was reported as normal. But on examination, he had word finding difficulty. He had decreased fluency and there were no long track signs. His comprehension was, simple comprehension was preserved. Complex comprehension looked impaired. So whether this was a stroke mimic or whether this was a left MCA stroke was the thing before we examined him. But on examination, it was very clear that this is looking like some language difficulty and there is a left MCA infarct. So it was ADC which showed us this thing. There is this temporal cortical hypointensity which is seen, whereas the diffusion was still to show anything. So we went ahead, there was angio was done, which was normal, and we thrombolized the patient. So after thrombolysis, patient showed improvement and his aphasia recovered in next few days. It became more apparent on the next day, but there was no increase in the infarct size. It remained what it was shown in this image. So this was again one case which could have been missed as a stroke mimic. And because it is language, there was no limb involvement. Sometimes if the MRI is reported normal, we tend to not thrombolize them. So for young colleagues who are listening, we should always try and examine. And whenever we are having doubt, better to thrombolize than not to. Sir, comments?
Yeah, Meenakshi, you can give your comments.
Sir, before we go to this, sir, I thought we'd hear the last word for the previous case also from you, sir. We didn't hear from you.
I was happy with the case, and as sir said, time was the most important key in that case.
No, sir's comments I asked.
Sir's comment, yeah, sir.
No,
Please.
See, according to me, nothing succeeds like success in this world. I mean, that's why we are having this meeting. Many times we go beyond guidelines and succeed, and that's how we learn. But I'm telling you that conventionally speaking, if I see a big infarct, which is entire MCA being involved, even on diffusion. You see, we talk about diffusion reversal, but it is not a common thing. It's extremely rare. People were very excited about diffusion reversal 10 years ago. They were.
Are we able to hear sir's voice?
Yeah, you are not audible, Dr. Sparsh.
Hello.
I think his connectivity is poor.
Yes. What would you do? What would you do, Meenakshi? You would have done a thrombectomy in this patient?
Yeah. ठीक है मतलब I just need a reason to kill time because आगे traffic is very bad. चलेगा हाँ चलेगा अरे बेसिक सूट के बिना चलो अबे मार्कर स्लो दिया
Yeah, can we go to the next case, please?
Yeah. So this was a case which had improved with thrombolysis, and it was giving a message that in stroke mimics or whenever in doubt, better to thrombolize than not. Coming to the next case. Yeah. So this is the third patient.
Sir.
Hello.
अरे अपना सेम गाड़ी है, चलेगा अपना सेम गाड़ी है.
I think someone
इसलिए बोल रहा हूं
to mute.
नहीं
Someone from admin.
Can you mute? Somebody is talking.
Yeah. So now coming to the third case. So this was a young male who was around 45 years and he had come with wake-up stroke. He had diplopia, giddiness, unsteadiness of gait, and he was confused and he was becoming drowsy. So we did his MR, diffusion and angio, and it showed complete basilar occlusion. Basilar was not visualized, and this is the diffusion. So this was a wake-up stroke. And on history from the wife, she said that he even had the symptoms last evening, but he had improved and he went to sleep normally. But this was a posterior circulation stroke with unknown time of onset. He got up at 6:30 and he came to the hospital at around 8:30. So we saw him at around 9 with this MRI. And first thing which we wanted was to see whether the brain was preserved or not. So this is a diffusion showing brainstem which was preserved. So because there was some history in which he also had the symptoms last night, we decided to go for mechanical thrombectomy directly without going for a IV thrombolysis. And fortunately, we were able to recanalize. This was the post-op CT, and it did not show any increase in the infarcts which were seen. And this is the follow-up of the patient at 1 month, in which he has recovered very nicely from the deficits of cerebral ataxia. So it can be very rewarding to treat acute infarcts in window with the right modality whenever available. So this concept of directly going ahead with mechanical thrombectomy in such patients wherein we don't know the window or when we are not sure, I think is also coming up and is taking gears. So in this patient, we went through the left vertebral and we found that left vertebral has got severe stenosis. We were not knowing about the right vertebral, but then the left vertebral was left the way it was because patient was not primed with antiplatelets. And on follow-up, we could find that the other vertebral was good. So we have decided to just observe him, and he is doing well on double antiplatelets and statin at 2 months now.
Yeah, does this patient got any infarcts in the brainstem?
Brainstem I showed, but it was just a bit in the pons if we see. Otherwise, it was okay.
Okay.
He had thalamus, he had bilateral PCA, bilateral cerebellum. So basilar was occluded. It was V4 left vertebral, which was severely diseased. Both vertebrals were diseased.
Yeah,
I think basilar was not in.
Yeah, maybe a chronic total occlusion. Maybe
yes.
A chronic total occlusion.
Yes. Fortunately, we were able to recanalize the basilar and we got good result. So direct mechanical thrombectomy whenever in doubt in such patients without thrombolysis can also help. Any comments?
Yeah, this patient has got only bilateral acute cerebellar infarcts only. And I think this what you did is actually a chronic total occlusion only. The other may not be that acute stroke may not have been benefited with this procedure, but in future he may not develop further strokes because you had open up the chronic occluded vessel. Anyway, that is a good thing because he was having a previous recent symptoms also, no? TAA like symptoms and also. Okay, so it's better to proceed also. But regarding the time and window and all these things, I think till now no guidelines has come regarding the extending this type of mechanical thrombectomy when we are not sure of the window period. And
the patient was deteriorating in front of us.
Yeah. So if it was a progressive stroke, definitely.
Progressive
stroke, you are sure if it is a progressive stroke, definitely go for it. DSA and mechanical thrombectomy for especially these type of chronic total occlusions, because the patient will definitely benefit.
Should we go to the next case, sir?
Yeah, I think Dr. Meenakshi is not there.
Now it's come.
Yeah.
Disconnected and came back, sir.
Yes, yes, sir.
Yeah. Okay.
Showing my fourth case. So this was a classic garden variety case in which we had a patient who was 65 and who had come within 2 hours of having a right-sided weakness. And he also started becoming drowsy. Clinically, it felt like it is large vessel occlusion. We went and did an angio. It showed M1 occlusion. And there was this deep gray matter which was involved, whereas the periphery was spared. So again, because it was 2 hours very much within the window, we did a bridging here, we thrombolized, and then we took the patient straight for mechanical thrombectomy, and we found that there was this inferior twig which was preserved pre, and post we were able to recanalize the patient. So the patient did well post-op and continues to do well. So this was a typical case in which bridging was done and patient improved. And last case, which I wanted to show, this was also within window, but it was at 3.5 hours, which I saw the scan. And she was an elderly lady, 75, who had just mild left-sided weakness. Her power was 3/4/5 on the left side. She was coherent. However, she would be sleepy in the ICU at 3.5 hours. She would wake up, she would talk coherently, and then she will again go to sleep. She would appear drowsy. So her angio was normal. The vessels were open, and she had pre-morbid diabetes, which was there. Her BP was remaining on a higher side. It was 180/100. So as per guideline, even though her angio was normal, I had given her the option of thrombolysis. We decided to thrombolize, and unfortunately, the first scan showed some bleed. This was the follow-up. Immediately, 12 hours later, we had increase in the bleed, and this was post-decompression. The hematoma still remains because the thing was not clean and they were not able to stop the bleeding. Decompression was done on the very next day after thrombolysis, within maybe say 24 hours. She went down after thrombolysis, and the going down started maybe 8 hours after thrombolysis when her BP shot up. Her BP was remaining 140/150, and it suddenly started going up. And I don't know what I missed in this case, but this was an unfortunate thing which happened to me. Maybe we have thrombolized more than 200, and this is the only one which has bled, and which has bled very bad. And this patient remained on ventilator, remained in the ICU for a long time. And now she's gradually recovering because right hemisphere stroke, we decided to be aggressive with her. But then she had a very stormy course. Her PTINR, APTT, everything was okay. So pre-morbidly, she was very good. Any comments, sir?
Yeah, you used the tenecteplase or actylase?
Tenecteplase. Now studies have shown we used full dose tenecteplase.
Okay.
I gave 15 mg. She was around 60 kg.
Okay.
0.25.
Okay.
This was a diffusion, but her vessel was open. Her vessel was open. Right M3, M4 were also visible. So, and she didn't have that much deficit. Her power was also around 4/5. Only thing, she was a bit drowsy. So should we leave such kind of strokes, and should we not intervene in these strokes when the vessel is open and when they are at that border of 4.5 hours? Or
yeah, that only thing is that the duration may not be that much correct, I think. Okay, because what we will decide on what they say. Okay, so anyway, the duration what they said may not be correct, and ideally, but as per the theory, if the patient is within 4.5 hours and this much infarct, definitely we will go for a IV thrombolysis.
And it was not seen on the flare. We usually try to have the mismatch and then go and intervene. So there was no flare thing which was seen. So we intervened and we thrombolized. And unfortunately, we had a bleed. So
I think the most important factor deciding the post-thrombolysis bleed is hypertension. We have to closely monitor the BP. That is the only thing which usually decides. Otherwise, associated comorbidities like hyperglycemia and associated chronic liver disease, patient was already on dual antiplatelet, all these things predisposed to it. Nothing was there in this patient.
No, sir. I couldn't find it.
Yeah. Okay.
Thank you, sir.
I think it was just a bad luck, I would say. We were bold enough to present this case to forum. I think just bad luck. Otherwise,
Yes.
it forms in that statistical criteria that is 6% of people have to bleed. So probably he belonged to one of those 6%, I think, because 100% would have taken up for thrombolysis. When you could show a case where you could thrombolyze up to 9 hours, I don't think anybody would miss out on a 3-hour window. 100% we do, and the scan also doesn't appear too bad. And with the MR angio also not showing any occlusion, there is no way I think we would have kept our fingers crossed without thrombolyzing. 100%, just it's a bad case, I think. And I'm happy you went and did it. There was one interesting information I can share from the Enchanted data, where it said if patients are on dual antiplatelet therapy. So there was a discussion about the use of low dose altiplase in those days, because the Japanese guidelines, it is 0.6 mg per kg body weight as against 0.9. So in the Enchanted trial, one of the things that was seen was whether this low dose altiplase was good enough. And there was only one subset where it showed some benefit. That was the patients who had been previously on dual antiplatelet. So we can extrapolate that information to tenecteplase and use tenecteplase 0.2 mg per kg body weight in those patients who are on antiplatelet, and use the regular 0.25, which we are doing after the ACT data, for all our patients who are not on antiplatelet. This is a strategy which we are following. We don't know right or wrong. We learn from experts.
Yeah, Meenakshi, can you hear me?
Yes, sir.
No, I completely agree with Meenakshi that there will be patients who will bleed. In fact, we have published a paper also on the predictors of bleed, and the biggest predictor is uncontrolled blood pressure. But there are some patients where there is no absolute predictor. We really don't know. Till now, we don't know that what is the predictor of bleeding. There are some patients, they are absolutely within the window period. And I think, actually, we have found there is a genetic mutation. Some people are prone to bleed. They have got a particular mutation because of which they bleed. And I think in future, in the personalized medicine, before giving thrombolysis, we'll be looking for that gene polymorphism. That's why everybody doesn't get hemorrhagic conversion, but some people develop hemorrhagic conversion, and there is definitely some cases. Otherwise, I don't see any reason that why she should have bled. So I think you can, we have to accept that risk. In patients, some patients, it will happen. I completely agree with Meenakshi on that. And about the previous case about that vertebral artery, I wanted to know one thing from you. On which day you started double antiplatelet in that patient?
We didn't do stenting. So double antiplatelet was started immediately after thrombectomy.
But that's also interesting. If you go to guidelines, I'm sorry, I'm going to guidelines. One of the things after in double antiplatelets is that they should be non-thrombolized patients. But you have put them on double antiplatelets, and there was no complication in these patients. That's also a learning point. If you see the guidelines, listen. If you see the guidelines in double antiplatelets, they say it should be a minor stroke, and it should be non-thrombolized for the fear of bleeding. But obviously, nothing happened in this patient, which is a big learning point for us.
This was not thrombolized.
Yes, this was not thrombolized. This was mechanical thrombolysis.
No, the previous one was not thrombolized. Okay.
And we had bridging in one. So I did do bridging in this case, but we started with single, and then she did well.
Okay. Got it. Thank you.
Yes.
Please go ahead.
Okay. So I'm done with my cases. We had 5 cases, and each of them had a message. So the first case which I showed said us that diffusion can reverse, and when early with a stroke, we should always be more aggressive whenever within that 1 hour, 2 hour period. Sometimes we can benefit the patient by reversing the diffusion, even in large vessel occlusion. So we should not put up our hands whenever we have that
Yes.
1 hour, 2 hour symptom onset patient. Second patient, one should thrombolize whenever not sure. It is always important to examine yourself and not depend on someone, because things can be missed. Third patient, direct mechanical thrombectomy can be done, especially in posterior circulation stroke, up to 24 hours if you show a preserved brainstem. And fourth patient, bridging therapy was done, and that is the standard thing which we do and can help the patient. But definitely one should be watchful after thrombolysis for improvement or worsening, and should not wait for improvement and take up large vessel occlusions for mechanical thrombectomy. And last patient, despite doing everything, there has to be caution for blood pressure, and we should be always cautious. We should counsel our patient appropriately about the risk of bleeding, because in this patient, I was at the end of my wits. I didn't know what went wrong, but she bled very badly. And after this, I was afraid for few strokes to thrombolize, and I would I would wait for an extra half hour to see what is happening to the patient after thrombolysis, which I was.
I just want to thank you very much. I just want to make two short comments. One is that in early days of thrombolysis, one of the doctors, who is very well known stroke specialist in our country, he said, none of my patients has bled in a conference. He said, I don't know why patients talk about bleeding. None of my patients has bled. I'm talking about 2003. I said, how many have you thrombolized? He said, 10. I said, your 14th patient will bleed. He said, how do you know? Are you an astrologer? I said, no, but I know data. Your 14th patient will bleed. After a few months, he met me. He said, Dr. Kaul, you're absolutely correct. My 14th patient bled. I said, yes, it has to. Your 14th patient has to bleed. You have not thrombolized enough. That's why your patient didn't bleed. So therefore, no. I think this was, you could not have avoided. As I told you, there is a lot of data which shows there is some genetic polymorphism which makes some people prone to bleed. Until we reach that stage where we perfect this technique, these bleeds will happen. But sorry, I want to come back to fourth patient. He's stuck in my mind because at that time I lost touch with the presentation.
So
but
this
the
was the
fourth
diffusion.
patient, did you stent him? Did you stent him? No.
No. This was a good artery, sir. This is the vessel.
Okay. No, I got it. So it was not stented. And did he receive IV?
Of stenting this.
Yeah. No, you did bridging. But you had IV thrombolysis also you had done?
Yes.
Okay. Got it. Yeah. That is the point I was saying, that sometimes, we go beyond guidelines. In guidelines, they have said if you have done an IV thrombolysis, then you don't put double antiplatelet unless you have stented. But, in a given case, that may not be necessary. We may go beyond that. And that is how we learn from these cases. So thank you very much. I think great learning and great messages. So over to the chair moderators for their final comments.
Yeah. Thank you, sir. It's time to...
Thank you, Dr. Akash. Thank you, Dr. Akash, for the interesting cases, and Dr. Satya for the interesting case and valuable inputs from our Dr. Meena.
Thank you, sir. Thank you for the opportunity.
So thanks all faculty.
Five extraordinary cases, sir, really. Fabulous. Unbelievable, really. And your angio pictures are phenomenal. Extraordinary, sir. Jealous of you. Straight away I can tell. Really nice, sir. Thank you, Shamlal, sir. Thank you, Professor Kaul, sir. And thank you, Dr. Satya.
Thank you, sir.
So it's time for the vote of thanks from Emcure. I thanks today for our expert speakers, Dr. Satyananda sir and Dr. Akash sir, for their fantastic cases. Then I thanks to our moderators, Dr. S. Shamlal sir and Dr. S. Meenakshi Sundaram for your expert comments. And of course, Dr. Subhash Kaul sir for your sir is our mentor and guide for this event, sir, because today we are celebrating the 76th of No Thrombosis Forum. So Dr. Subhash Kaul, thank you so much, sir. Keep guiding us on this forum. And today, around 376 doctors have enjoyed this scientific and practical session and knowledge sharing forum. And I believe they will carry the message and the experience to treat their patients better. So thank you so much, sir. I thanks all the delegates. And thanks all of you, all delegates, and happy weekend. Good night, sir.
Thank you. Happy weekend
Thank
and
you.
Merry Christmas.
Yeah.
Happy
Merry
Christmas, sir.
Thank you, sir.
Good night, sir.
Good night, everyone.
Thank you, sir.